macroscopic level, they exist to kill. They travel, they attack, they hide, they even gather together in defense maneuvers. Pathogens are the enemies of every member of the healthcare team. On Pathogens and PPE, we give you the tools you need to fight these threats and win. So sit back, tune in, and let's make these microbes tremble at the sound of your name.
Hello and welcome back to episode 3 of the Pathogens and PPE podcast for season 2. We are diving into everything about robotic instrumentation today, so don't go anywhere. We will be right back with a message from our sponsors. Hello and welcome back, everyone, to episode 3 of season 2 for the Pathogens and PPE podcast. I am Jill Holdsworth with Infection Prevention, and I am here with my co-host, Rebecca Alvino. Rebecca, thanks so much for being here again with me to co-host this awesome podcast.
Thanks for having me back again. Another topic I am absolutely excited to talk about.
Awesome. Now, I know that you were on the last episode with me, but just in case somebody didn't listen to it, which if you didn't, you need to go back and listen to it. Why don't you give us just a brief background of who you are, what you've done, and how you got here?
Of course. So I am Rebecca Alvino. I am specifically a perioperative procedural infection preventionist. I am the System Director of Hospital Epidemiology and Infection Prevention at UC Davis Health in Sacramento. I have been a System Director of Sterile Processing at another UC health system, and I was an OR nurse once upon a time for about 15 years. So as I mentioned before, when we talk that SPD, OR, IP triangle, my career embodies it completely.
That's awesome. And that's what makes you so cool. You've done absolutely everything, and you can talk the talk. We have 3 amazing guests here with us today. Tamara, why don't you give us a little bit of background and history about where you've been, how you got to where you are today, and what your history is with infection prevention?
Well, good morning, Jill, and thank you for having me. I've been in the field of infection prevention going on 16 years and done a little bit of dabbling in travel infection prevention for large organizations such as Kaiser, and actually currently work for the government. And I've also done some infection prevention consulting. I own my own company now, and Tamara Behm Infection Prevention Consulting, and done some work for industry, worked for Sterile for 4 years, specialized in high-level disinfection and sterilization, multiple publications, including some for APIC and endoscopy, and have a new publication coming out for AORN next year. So a lot of background in infection prevention. So thank you for having me today.
Vanessa Frank.
All right. Well, thank you. I'm currently the clinical resource manager for Advantage Support Services. I have been in love with sterile processing for, I think, almost 15 years, working in a hospital for 13 of them. And then I went to the dark side. Fun fact, they did give me cookies. And
I was going to say.
I did get cookies, and I worked for an instrument tracking system company for a hot minute before Advantage called and asked if I'd be willing to join their team. So I'm really excited to join this conversation with this rock star group.
And we're super happy that you are here. Our next guest is Rebecca Peplau. Why don't you give us a little background about you?
Hey, thanks for having me today. I'm happy to be here with you ladies and talking about this topic. So I am currently a clinical education specialist with Healthmark, a Getting a company. And prior to that, I've worked in many different positions within sterile processing and really favored working as an educator. I felt like I had the most impact. I am also a member of several AMY working groups alongside the rest of you. So that has been one of the most pivotal points of my career too, because, you know, we're putting our knowledge to the ground and working on those standards together. And I'm currently the president of my local HSPA chapter. I think Vanessa is as well. So we'll give, the props there. But it's definitely something that sterile processing has been in my life for over 20 years now. And once upon a time, I started as a veterinary assistant and then technician doing this in the veterinary OR. So yeah.
Wow, that's cool. I didn't know that about you in the veterinary OR. That's awesome. And kudos to all of you for being so involved in your professions. We really need that. And I'm glad that you mentioned the AAMI standards, because we're always cheerleading for more people to get involved and those that do the frontline work to be involved in the standards committee. So thanks for bringing that up. All right, so let's dive right into the world of robotic instrumentation. This is going to be an exciting episode. So let's just talk first as a kind of a general overview. How has the world of robotic surgeries changed over the last 5 to 10 years? And let's start with Rebecca first, if you want to try and tackle this one.
I feel like the instruments themselves, when we think of robotics, we can't just limit ourselves to one type of robotic, right? We have robotics for total joints. We have robotics for neurosurgery, but primarily we have general surgery, GYN, GU robotics as well. I think that the focus for today will probably be more on those general robotic instruments, but I feel like with total joint replacement, they've come a long way, and that precision to do better for the patient. When we're talking about more of the general robotic instrumentation systems, I feel like the techniques have become more advanced and they're able to do more for the patient with some of these robotic techniques, more advanced surgeries robotically. But I feel like the instrument designs have kind of gotten more challenging for us, and they were already super challenging for us to begin with back with older robotic systems. So that is a cause of concern, but I feel like on the patient end, there may be some more advancements, but on our end, there's some problems we need to look at.
Rebecca, I'm glad that you bring that up, because you're right. And I remember somebody who I consider to really be a pillar in sterile processing that I used to work with explained to me once how, as surgical technology has evolved, that doesn't mean that the sterile processing technology has kept up, right? And it's required a lot of skill build amongst our technicians and professionals to keep up with the complexities of those robotic instruments. Have you experienced, you or Vanessa, having a robot system brought into your facility, whether it be general or orthopedic or neurosurgical, and finding that your SPD just can't support the reprocessing in the moment?
Yeah. Actually, I worked at a facility where we rolled out a robotic program there, and the sinks were not big enough. There was no critical water for final rinsing. The washers were not compatible. The ultrasonics were not compatible. Like, the arms could not fit in those ultrasonics. One of them did not have enough power. However, we were told by company reps that we can just make it work without having adequate flushing components for the arms in the ultrasonic. And that was incredibly frustrating, to treat a more complex instrument than a standard laparoscopic instrument with a lesser processing protocol.
Yeah. So my experience is actually opposite, because the facility that I previously worked at, they had built a brand new sterile processing department for us prior to the robot physically coming in. So it was planned for. So we did have sinks long enough, and the ultrasonic had the capability with the basket and the hookups. And we even had the fancy washer rack and everything to get it through that decon side. And then, it was just a matter of training our staff to follow the time consuming at times steps to appropriately process them, because they look simple from the outside, but they are complex on the inside.
What do you think the most difficult pieces of this process to reprocessing robotic instruments would be?
As far as my experience, it's the flushing step, because when we tell people you flush the lumen, the automatic mental picture is that, well, there's an opening on the other end where it all goes out. And it's actually kind of a loop, as it was explained to me. It goes down and back around. So if the flushing isn't at the appropriate pressure, either it's not strong enough or it's too strong, and it's not done for the amount of time required, then we can't put a borescope down there and see what's down there. It's a mystery.
So for those who may not understand and that may be listening, how do you know how to get that right pressure?
So it usually states in the IFU. I believe it does state in the IFU, and not a lot of sterile processing departments have the setup to monitor their water pressure.
Mm-hmm. That's very
whether
true.
It's an automated flushing system, and that usually is another different manufacturer, completely different IFU. You have to have them come in and make sure it's calibrated. And then you still don't have a way to actually visualize the pressure. Hey, the water's coming out. Great. And that's what we got.
Yeah. And some of those companies will give you sink attachments where, the water will be pressurized coming out of this tip that attaches to the components of the robotic system. But without a gauge on there, do you really know? Without temperature monitoring, do you really know? Without a timer on your station, that's the problem too, is because there's less automation involved with so much of these manual steps that you have so much room for human error, interpretation of those IFUs. So there are a lot of room for error there, especially when the amount of bioburden that can accumulate on the distal tips of some of these instruments is so caked on, and it's really difficult to remove that soil without damaging those fragile pieces like cables. For me, one of the parts of reprocessing certain robotic instruments is drying. I feel like the design does not allow for proper drying at an easy way. A lot of facilities don't have adequate methods for drying these instruments, which can lead to accumulation of biofilm inside of the devices.
Okay, I think that was a lot to unpack. I do want to go back to something that you said, Rebecca, before we dive more into drying. So you mentioned the pressure, the temperature, you mentioned all of those things, the timers. So do you feel like if you're going to be successful with reprocessing robotic instrumentation, that you need to have all of those things present if you're truly going to follow the IFUs and be compliant?
Yeah. In addition to the proper lighting and magnification. Because, looking at those cables and inspecting them for bioburden, that's another thing. Like, you need to have well-lit areas and magnification for that.
Can I ask just one thing? When we're talking about the bioburden and the cables, I've seen some very creative methods employed trying to get eschar tissue and other soils that are retained from its arrival from the OR to sterile processing into decontam. Have you seen some cringy things that you would just, to our technician professionals, say, please don't do this. You may damage the cables. It's very enticing. There is that pressure to produce, but at the same time, what have you seen and what risks are being presented as a result?
I mean, when I was a newbie technician, I was explained that you can take the tip of a scalpel blade and kind of try to scrape that char off of the scissors or a hook or any other charred debris on there. In addition to, you can use a wire brush so long as you cover the cables. So that improper education and that improper monitoring or auditing of the processes could lead to employee harm and then instrument harm. I've seen tip protectors used in the OR. I feel like, and maybe you guys can speak to this more about when they're used in the operating room, a lot of the times my understanding is that the instruments cannot be removed from the robot to expedite point of use cleaning, even if they're done with that arm, which can make it so that bioburden is really tough to get off because they can't take the arms off necessarily. Are you guys able to speak on that a bit more for folks?
Yeah, so the arms can be switched out aseptically, but it's something that happens really when you're not going to you only have so many robotic arms to be able to use intraoperatively. So it's not as simple as handing up an instrument to the surgeon. There is a little bit of a process to changing those arms out during robotic surgery. So it's been a while since I've been in that environment, I will admit, but there can be a little bit of a process to it compared to an open surgery or even a laparoscopic surgery where perhaps you could just create another incision and add another trocar should you need it.
Yeah. I think that's part of the problem too, is like you can't just pass it off to wipe it or start that removal of bioburden. It takes longer.
To add to some of this discussion, we've covered a lot of challenges that already exist. There are probably more we haven't covered. With all of these challenges that the technicians are facing, do you feel they're taking shortcuts? They're missing steps? What do you think is actually happening when things come to SPD to get reprocessed? And I'll start with you, Vanessa.
Yeah, I think I've said this before. No one goes into work in SPD intending to do it wrong. We don't walk in and go, you know what? I'm going to skip half the steps in reprocessing my robotics today. But it is a time-consuming, complicated process with multiple brushing and flushing and spraying steps and rinsing and soak times. If you are short-staffed or you have a bottleneck and you are rushing to just try to get things through, then it can be easy to almost, I want to say, forget the steps, but to be like, man, you know what? I'll do 20 seconds instead of 30 seconds. I'll brush and, it looks okay to me visually. I'm sure there's no bioburden there. Speaking to, the lighted magnification that Rebecca mentioned, we all have different eyesight. Me personally, I'm blind without my glasses, and the face shield and decon doesn't help. So I don't think it's intentional, but without an education plan that refreshes everybody on the proper steps and handling, I think it's easy to slide into those shortcuts.
I'm a little bit of the opposite because I've seen negligence, and I feel I'm going to call it that because when you ask reprocessing technicians to repeat back to you the steps for reprocessing those instruments, they're doing it by the book. But when you watch them put it into play, they're not following the IFUs. And then there was one facility I went to where the arms were soaking in the sink. After they came down from the operating room, there was a timer. Water temperature was not compliant with the IFU. And instead of doing any type of manual cleaning, they just threw them in the sonic after that and then put them in the washer. And that was pretty alarming because I asked her, I was like, hey, what are the steps in the IFU for processing this? And she said them back to back to back, but I watched the whole process and half of those things weren't included in her work. So it is something where leadership needs to audit these processes. When you have a complex instrument, you need to make sure that the complex steps involved with reprocessing them are followed to a T. And whether they can't be accomplished because of resources missing from the department, or if it's because of lack of education, you have a couple paths you can choose to make it right. Feed your team the information that they need. Give them in-services and education. But then that's where your leaders need to step up and monitor the process. And if people aren't being compliant, there needs to be steps taken. And also doing your own quality audits with cleaning verification methods and making sure all of your equipment is in line to reprocess these things as well. Holding people accountable.
In your experience, what's the best way to do some quality monitoring on something like a robotic arm?
So there are tests out there that you can use for robotic arms, swab kits. And so the use of that, but also in addition to testing your ultrasonic daily for cavitation and soil removal, testing your washers daily, making sure that if you're ultrasonic, you have lumen hookup tests to make sure that those ports are doing their job. A lot of those ultrasonics too, you have to know the structure of them. How many water pumps do they have? If they have more than one, is all that water getting sent equally to different parts? Sometimes if you have one pump in your ultrasonic and you have 10 lumen ports, if you have one instrument hooked up, there's a steady jet of water coming out of it. But once you hook up 10, it's barely dripping out. So you really need to be testing each, your ports in your ultrasonics as well to make sure it's doing their job.
It's a great point. I'm just thinking as an IP listening to this, like, wow, we probably aren't looking at all of those things when we go in to decon, but I know IPs are always wondering, like, what kind of test can we do? Can we do a protein test? Can we do all of these things? But I think a lot of IPs know about the washer test. I don't know that a lot of IPs know about the sonic test or the things that you can look at to make sure that the sonics are working right. And I find sonics fascinating, just the way that sonics work. So if you're an IP listening and you don't understand sonics, then start Googling and studying sonics, because they really are fascinating.
And it's not just, it's each component in your ultrasonic that you have to make sure is working, and checking it daily for damage, There's a lot to it just with decontam, but that's just one of the steps.
Yeah, and I will say, when I was doing an audit in sterile processing, I asked why were these robotic arms not going through the sonic? And they said, we just don't have time. That's not an okay answer. I understand that is the answer to my question, but it's not an okay answer. So that's to your point, Rebecca. Why are things not being done correctly? And if there isn't time, why? Where's the breakdown? Is it staff? Is it not enough sonics? And I've seen that answer through many facilities I've been in. We don't have enough sonics. So if our workflow is not being supported by the equipment, then we need to figure where the bottleneck is and get another sonic if we need to. So sometimes you need help assessing that, and that's fine, but we have to figure that out. That's an easy answer, but the answer cannot be, we don't have time, so we just skip that step.
And I think that the vendors and the manufacturers need to have more hard guidance in their IFUs. Years ago, one company had one instrument that required an ultrasonic where the rest of them did not. It was recommended, but not required, right? Here we are a few years later, and I'm not sure if the IFUs have been changed to say required or not, but it is something where many products now are designed to, like, your general workflow for these. It's assumed that you're going to do each one of these components. So manufacturers need to have a bottom line. We need to hold them accountable where we can.
How do you think that we can help SPDs get to compliance with these IFUs for our robotic instrumentation? How can we help them get there easier? And Tamara, I'm going to start with you.
And I think you and I have spoken about this before. One of the big hangups with the IFUs, specifically with robotic arms, is if point of use care is not done properly, you're setting up the SPD for failure to begin with. So it all starts in the OR. And most ORs are not aware of the 5 steps that they're required to do in the OR. So before it ever leaves the OR, they've got to dispose of the items that are disposable. They're supposed to flush. They're supposed to open all the tips. They're supposed to make sure the bioburden's removed, and they're supposed to make sure that it's placed back in the right container. And they don't do most of that, if any of it. So that right there makes it very difficult for them to then remove anything that is stuck, anything that's inside the channels, right? We don't have anything capable of seeing inside the channels. We don't have anything capable of truly flushing fully once those channels have any type of bioburden inside of them. And if you get any type of the burn, when they're using the cautery with the tips, that just sticks in forever to the tip of them. And what I do find is oftentimes they'll sell the new robotic arms or, the extended use arms to the ORs now, and they just sell everything, but they don't do any training in the OR about the point of use care. So again, that just sets up the SPD staff for failure. So then the SPD staff get it, and they're spending long, long hours on doing the cleaning. The other problem is, which this happened a couple years ago, they shortened some of the IFUs, but they only shortened the IFUs if you purchased a company I used to work for, a washer that had a special claim for the arms. And so the sales guys were running around telling all the SPD people, oh, it's a shortened cycle now. You can just do this to the arms, but they didn't have the washers. So they were leading the SPD people down the wrong path to cleaning a shortened cleaning, which was totally incorrect because they didn't have the equipment to follow that new IFU. So, you have to be careful with the equipment you have, the people who are instructing your staff on the IFU, right? We put a lot of trust in our salespeople. We put a lot of faith in the people that are coming in to train our SPD staff. And we really have to remember that we have to put that onus on ourselves, like as the leader or even the IP, to really dig into the IFU for the devices and not necessarily put all that trust in the people who are coming in to sell the devices too, because I'm telling you, they'll sell ice to an Eskimo.
I want to go back to those 5 steps that you mentioned that they're supposed to do in the OR, because I will say many times when I've been in SPD, I just see these arms thrown in the case carts on top of everything else, which really makes me want to cringe because I know that things are just going to get damaged anytime they're just thrown in the case cart. But now I'm kind of blown away thinking, wow, obviously things weren't done correctly in the OR. So Vanessa, what do you think? What have you seen happening as far as things that are supposed to have gone right in the OR? They come to SPD, they're not done. Do we just keep moving? Do we give the OR feedback? What actually happens out there?
Yeah, so it's funny. While Tamara was talking, it reminded me of those steps that need to be done in the OR: removal of the bioburden, opening the working ends, and there's the product out there. It's like a little tip cover thing with a solution in it, and magic, it's going to make your reprocessing easier. All you got to do is stick the distal end in there, and that is so false.
Yeah,
because it gets stuck in there, but it has not been cleaned of, whatever bioburden that can be cleaned off, because we talked about it being burnt on there. They don't have the appropriate tools to clean in the OR. That's not what we expect them to do. But also it gets stuck in there, and then the jaws are clamped shut anyway. So we all know if it's not open, it's not getting exposed to what it's supposed to be exposed to. Just communicating that, like, hey guys, I know you're hurrying to turn over the room. You've got another patient coming in, all that good fun jazz. Take 5 seconds, twist the little knob, and just pop the little ends open. Where I previously worked, we did have a decent working relationship with our OR teammates. So we could call them up and say, hey, this was in the case cart. This wasn't in the case cart. You had a tray stacked on top of the instrument arms. It might have been a new person who hasn't really been kind of enfolded into this partnership that we built. And just having that open communication and calling out the things that need to be improved on. I mean, it doesn't have to be aggressive or anything like that, depending, again, on your relationship. But I think it's totally appropriate to have communication both ways to ensure the process is done properly. Because at the end of the day, we go home and we complain about our coworkers, but there might be a patient who's having problems because of this.
Yeah, absolutely. And I don't want to run out of time before we dig into drying a little bit. So, Rebecca, I want to jump back over to you and make sure that we cover this adequately. So can you just briefly describe again why drying becomes so difficult with these instruments?
Yes. So the design of these instruments is tricky because there's not a real way for them to drain properly. So the bulk of your robotic instruments are going to have a square rectangle block that attaches to the robot in the operating room. That is where your flushing occurs. That is where all of that water just kind of gets in that block. And you have a lumen that goes up the shaft for the scissors, and then there's an exit point. But for a lot of the other ones, it stops about maybe 2 inches or 1.5 inches from the distal tip, and it's just an open hole there. So all of that cleaning chemistry and water, detergent, etc., is just in there. And so if you follow the IFU, everything should be rinsed out, but there is no way that you can decontaminate because of the shape of the instrument. A lot of folks tend to hang them where the block is on the top and the distal tip is closer to the ground. You're creating a pool of water in that block where it's not going to the distal tip. It's just sitting in that square. You have to flip it the other way, but then the problem is the holes, the flush ports, even if it's positioned the correct way, that fluid can't all make it to those holes. So you really need modalities for drying that have hookups for those, and they have timers on them. Now, there is a white paper out there that shows ineffectiveness of standing there with an air gun, because even if you're standing there with an air gun, you're not going to get this moisture out. And how long does it take for biofilm to start? Right? So here we are thinking about moisture inside of these, and I was taught just shake it, stand there and blow it out with the air. But we know that that is not an effective way. And our technicians do not have hours to stand there and dry these things. And I had taken some that were at end of life and cleaned home to do some experiments with. And there was moisture that sat in some of those instruments for close to 3 months, and they were still wet inside.
My goodness.
So
those are the ones I want you to culture, Rebecca. Yeah. The ones that have the 3-month moisture.
And we can do this. And the thing is also, I wanted to talk about the design where those it cuts down to like a 90-degree angle or a sharp angle, where if you were to force a borescope down that, you would damage the channel or damage your borescope. It's a very forceful push that you have to get it down to look further, and that's why it's not recommended. You can try it, but you're probably going to damage your borescope or the instrument, and it's not recommended by a lot of the manufacturers. It is a problematic, the design with the drying. So realistically, you want to make sure that you have done your research about drying, and then you guys as the IP folks, you can chime in about water quality and how long it takes for biofilms to start growing. So it is concerning that, you have standing water inside of these instruments.
Well, and I'm thinking about not just the standing water, but if we do end up cutting corners in an effort to just get something packaged and back out on the floor into inventory, what else are we going to find in there beyond just, even if we had pristine water quality, if we're cutting corners, I'm afraid to know what we would find.
And those cables, they're the same cables throughout. I mean, they move, the way the cables are designed is that they run up and down the shaft, but they're coiled around components in the box of that arm. And so the same cables being exposed to that same fluid inside of that shaft, it ain't going nowhere. So you have to think about what there's potential to grow on those cables inside from the lack of being able to clean in there. Of course, it's validated by the manufacturer if you follow the IFU, but the inability to dry, you can't stop microbial growth. So you need to think about that as well.
So there's cables actually running down the inside. I didn't even know that. I didn't even know that.
You should see some of Rebecca's pictures. All right, ladies, as we start to wrap up, I'm going to ask everybody to answer the same question. And I'm going to start with Vanessa. And the question is, what message would you ask or send to the manufacturers of these instruments if you could get them all in a room and you had their attention all at the same time?
Well, that's a question.
I know, I'm sitting here thinking the same.
So one thing that I keep kind of, running across over the years is instruments are designed for use, not reprocessing. And I get it because the OR, they're the ones actively utilizing these and stuff. But at the same time, if we can't clean it and sterilize it, then it poses a risk to our patients, and it's a vicious, endless cycle. So I would request input from sterile processing, whether it's one of our organizations of awesome, smart people or something like that. So Rebecca knows, but putting us at the table for these conversations. Hey, we're looking at redesigning our instrument arms, our robot arms. Like, what can we do better for the whole instrument cycle, not just usage, because that's a short period of time that the instrument is being used. And then the reprocessing steps, we all know, are usually a lot longer. So letting us give input, we know what we can and cannot do in our decons. And if they just keep kind of throwing it out there, eventually it's going to come across that we can't do anything for it. They'll all be disposable.
All right, Tamara, how about you?
I'm along the same lines as Vanessa. I says it's one thing to create a device that's to be used for a less invasive procedure, which we all absolutely love. But it's another thing to realize that several years after making that device, now you have to accept the understanding that that new low invasive device could possibly be causing harm with use over and over again. And you can't turn a blind eye to it. And you have to understand that the instructions for use that you've given and provided has gaps. And it is humanly impossible to clean the device appropriately. You may have shown through processes in a controlled lab situation that it can be done. But the people that are working in a sterile processing department is not a controlled lab.
Chaos.
It's chaos. It's not a controlled situation. And you have to accept evidence as it's being proven to you, because healthcare is an evidence-based practice environment. And the same lines that Vanessa is talking about is you have to involve infection prevention and end users in research and development, in looking forward to making new devices and new practices moving forward so you can make better devices.
It does make you realize, Tamara, just from what you're saying, if these folks from these manufacturers have ever really tried to clean their own devices in an actual sterile processing department outside of their own labs. I would actually love to see that. Hopefully somebody is listening right now that is like, what a great idea. And maybe they'll contact somebody and actually do it. All right, Rebecca Peplau.
I would love to, I agree with that too. I think that getting the reps hands-on education, reprocessing, not even just the reps, but the folks that work on manufacturing the design of these instruments, getting them hands-on in the hospitals to physically, our brains have changed that we need to learn with hands-on activities. Could you imagine if creators of these devices were forced to have to go into the hospital systems and actually have so many hours, before they can suggest a new design or something like that to
amazing.
The FDA? Right. But you have to, our brains have changed. We need to learn differently. Hands-on experience coupled with the textbook and lecture stuff is critical. So I think there needs to be some more education, at least on the sales reps too, because of my own experience where I was told, your Sonic's fine, but we know it doesn't have the attachments. We know it's my instruments, when they sit in it, I have to bend the distal tip so that they fit in here. And the rep is telling me that that's fine. That's not okay. And I think that we have to do studies in our own departments to show, okay, we can't take shortcuts. This is exactly how long each step of the process takes. Present that up the chain. Data collection is critical to ensuring that departments get what they need, and presenting that and that communication to your upline is critical. But I think we just need to stay abreast of the current changes. When new systems come out, we need to talk about it and share that, and continue to do our own research on it as well.
Wonderful. And Rebecca, Alvino, do you want to take us home?
Sure. I echo what everybody else has already said, because I think these are really well taken points. And with having either the education specialist or the sales rep understand what the real world conditions are in a very busy sterile processing environment, to have the input of sterile processing professionals and infection preventionists into the design of these, it really is a partnership, and to respect the expertise. This is not a department. These are not professionals that, as Vanessa said earlier, come in with the intention of trying to do the wrong thing. They're really just trying to see that at the end of this, there's a patient on the table that's receiving a surgery and they want to make sure that their surgery can happen, but there has to be a corner cut. That's a very real pressure that the sterile processing technician has to deal with in the moment. And we're talking about these very intricately designed devices with very extensive IFUs, trying to shorten it by saying, oh, if you install this brand new washer with these validated racks, that's going to solve all of your problems. Well, especially here in California, where nothing is plug and play when it comes to equipment. That's not feasible. And there are facilities out there that are looking to robotic surgery as a real revenue stream, but they don't want to make those types of investments. So respect the expertise of the professionals and listen to them when they say, this is what we're contending with.
Thank you, ladies, for being here. This has been a jam-packed episode with tons of information about robotic instrumentation. I think that we have proven that we have a lot of work to do on the manufacturer side, on the reprocessing side, and on the IFU side. So hopefully, if you're listening to this, you have some go and do's immediately. And hopefully there are also some manufacturers listening who can help us progress in this crazy world of robotic instrumentation reprocessing. Thank you for listening, and we will see you next time for episode 4.
Jill, there was a lot to unpack today, and I'm glad that we hit as much as we did about robotic instruments. There's so much more to talk about. We could have gone on for hours talking about robotic instrument challenges. I just can't wait to see what's in store with some of the studies that are emerging, and hopefully if our manufacturer partners are listening, can they, if our manufacturers partners are listening, can they just take heed a little bit from this discussion today to say, wow, we really need to reach out and start including a little bit more dialogue around the design of these instruments and how feasible it is in real world conditions to reprocess these.
I totally agree. And I will tell you, I learned so much from this podcast. And I'm so glad that we decided to do a topic on this. I mean, things from the sinks aren't big enough in some of these sterile processing areas to you have to make sure the pressure of your water is enough. And how do you even do that? I'm still kind of stumped on that one. How do we even know that we're doing that part correctly and that we've got retained water in some of these arms for months? That to me is terrifying. And the drying cabinets, the drying options, and how a lot of people are using air guns and they don't work. I mean, there's just so much here that sets us up for failure. And we just need to pay a lot more attention to this. We need help from the manufacturers and the reps so that we can help make this easier to be compliant for our sterile processing departments. What a great episode. I think there's going to be so much more conversation about this topic. Thank you all for listening. Keep fighting dirty and don't forget to wash your hands.
Thanks for tuning in to this exclusive podcast series on pathogens and PPE. For more information and clinical resources to help you fight dirty, make sure to follow us on social media by searching for Beyond Clean and Transmission Control.